Good morning, everybody. And first of all, I want to thank the organizer to invite me to this very prestigious appointment on stone disease. The topic that I have to treat is a little bit complex, and it can be subdivided in 3 subtopics: the diagnostic of renal colic, the planning of stone treatment, and the modality of follow-up. About the diagnostic of renal colic, I think that there are definitive statements that, of the guidelines that state that the non-enhanced computed tomography should be used to confirm stone diagnosis in patients with colics. And this is stated with level of evidence 1A and grade of recommendation A. So it is quite definitive. But have a look to the possible alternative imaging options in this case. If we look to ultrasound, what we can say is that ultrasound has had a very high sensitivity for renal stones larger than 5 millimeters, and are also very good for diagnosis using hydronephrosis and, in this case, the presence of the stone. But they have a poor visualization of the ureteral stones in absence of hydronephrosis, and they gave poor or no information on renal function. And obviously, they have a great advantage because they are cheaper and they don't involve exposition to X-ray. We can have some information on renal function by the thickness of the renal parenchyma, and we can have some information about associated space-occupying lesions, such as cysts on tumors, but we have not relevant information on urinary malformation of the ureter or also of the kidney. And we can have additional information on perirenal lesion as urinomas or hematomas. This can be important because they can be associated, the urinomas, to renal colic, and hematomas can be associated to some type of treatments. And the use of the Doppler ultrasonography can give some additional information on renal function by resistivity index and by the demonstration of the ureteral jet. And it can also enhance sensitivity by the demonstration of the twinkling artifacts that you can see on the right of the slide, that can also detect stones that are smaller than 5 millimeters. Plain X-ray obviously is very accessible and inexpensive, but has a lot of limitation for the demonstration of the stones in the middle section of the ureter, but also obviously for the demonstration of radiolucent stones, and give no information on genitourinary condition. The possible use of plain X-ray can be the differentiation between radiolucent and radiopaque stones. And when you were able to demonstrate a stone the first time, it can be useful for comparison during follow-up. And so we will discuss that after. IVP is a very good modality for the demonstration of the anatomy of the urinary tract, and also for the evaluation of the function of both the kidneys, and can also give help to the diagnosis of our urinary disease. But there are problems because the quality of the imaging can be very different from one case to the other, because it needs a very good bowel preparation, and it depends also from the habits of the patients. And it involves also the use of contrast media, and so it exposes the patients to a possible morbidity. and require sometimes delayed images when the renal function is poor. You can see that for the demonstration of the malformation of the kidney or of the ureter, the intravenous pyelography is a very good modality of imaging. We have, at the beginning, stated that non-contrast computed tomography is the gold standard at the moment for the diagnosis of renal stones. The possible problem are that this modality is sometimes less accessible and relatively more expensive. And another problem is that is give no measure of renal function, and sometimes it can be dangerous. And the more relevant problem is the exposure to radiation. In this graphic, you can see that with computed tomography, it is possible to demonstrate 100% of the stones of more than 1 millimeter if they are calcific, or more than or of 1.4 if they are radiolucent. And look at the problem of the radiation. You can see that regular dose non-contrast computed tomography can expose to about the double of an IVP or 10 times a plain X-ray. There are protocols to reduce the exposition, and in this case, the value of exposition to radiation are more acceptable. About the planning of stone treatment we have more definitive suggestion, but the guidelines of the European Urological Association state that renal contrast is indicated when planning treatment for renal stones. The level of evidence is only 3, but the grade of recommendation is E. What we have to know when we plan to treat a patient. We must know about the stone location, the size, and the shape of the stones, the condition of the urinary tract, and possibly also the renal function. As you can see, we have 3 options: IVP, tomography, contrast enhanced tomography in this case, and the association of ultrasound and plain X-ray. And as you can see, IVP and computed tomography give the best for all the 4 information we need, because they give excellent information on location, size and shape of the stones, condition of the urinary tract and renal function. And on the contrary, you can see that the use of the simple association of plain X-ray and ultrasound can be useful in order to demonstrate the location of the stones, but there are not sufficient information about the size and the shape of the stone, the condition of the urinary tract, and limited information on renal function. So you can use this option only if you have a previous imaging by IVP or computed tomography for a precedent episode of stone disease, and if the stone that you have to treat is very simple. Another point that we must make is that you have to verify your information when you plan a treatment in an extracorporeal shockwave lithotripsy. You have to confirm your information of the stone location on the basis of your machine, because sometimes it's not possible to have the same information you have in your pre-treatment imaging charts, because on your machine the stone is not demonstrable because of the limits of the imaging of the lithotripter. Another point that should be pointed out is that it's important to have information about the skin to stone distance, because obesity is a significant predictor of success of shockwave lithotripsy, and it is demonstrated that when the distance between the skin and the stone is more than 10 centimeters, the possibility of a success are reduced. Another point is that stone density can also be a predictor of the success of the treatment, and computed tomography can give you information about stone composition. You can see that opacified stones have the higher stone density at computed tomography, and that we have middle values for struvite or cystine stones and lower values for uric acid stones. And this information can be also obtained with low-dose unenhanced computed tomography, as is shown in this picture that is related to an experimental study in an in vitro phantom model. Again, when we plan a ureteroscopy, I think that it's important to stress that it should be present a fluoroscopy apparatus in your operatory room, because with a fluoroscopy during the procedure you can check the condition of the urinary tract, and then you can also check the position of the stones during the treatment. So I think it's relevant to state that it is useful, perhaps very prudent, to have a fluoroscopy during the treatment. For percutaneous nephrolithotomy, it sometimes could be useful to have information about the position of the organs surrounding the kidney, in particular in order to avoid lesion to the colon or other organ. About the follow-up, the gold standard to confirm the presence of fragments after lithotripsy is obviously an endoscopic exploration. But if we compare the result of nephroscopy with the result of plain X-ray or computed tomography, we can see that computed tomography can demonstrate all the stones that were demonstrated by flexible nephroscopy. So computed tomography can be also in this case the gold standard to demonstrate the presence of residual stones after lithotripsy. And in this study, it was demonstrated that patients that were judged stone-free by plain X-ray alone, in about 10% of the cases had stones at the ultrasound, and in 20% of the cases with CT. So the authors concluded that the routine use of computed tomography can give more information in patient controls after shockwave lithotripsy. But the problem is that you have better information, but this implies a lot of radiation exposure. And in this study of the group of the Duke University, it was demonstrated that in 20% of renal stone patients, the radiation exposure limits that was 50 millisievert was not respected in the follow-up of the patients. So the problem is that repeated diagnostic imaging can imply the risk of cumulative radiation exposure, because the patients are recurrent and the patients are, in most cases, young at presentation. So we have to consider that we must use alternative imaging method for follow-up, and this study demonstrated that when the stone can be seen at the CT scout, it is also visible in plain X-ray. So this happened in about 60% of the cases. And in these cases that are a relevant number, you can plan your follow-up with X-ray, plain X-ray only. So plain X-ray can be accepted as a first-line diagnostic tool for follow-up. And we have also to consider that ultrasound has a limited accuracy for detecting residual stones, but is highly specific and reasonably sensitive for detecting hydronephrosis. So a combination of these two types of imaging is safe and effective in postoperative follow-up. And low-dose CT should be reserved only for difficult cases, by example, obese patients or the radiolucent stones. Another option that you have to consider is to tailor your follow-up in relation to the previous recurrence rate of the patients in order to lengthen the interval between the radiological studies, and in this case also to reduce the exposition to X-ray. Okay.